Thank you for introducing me. I'm also honored to have the opportunity to speak at the APCIS meeting with the title of Anti-HLA antibody analysis and cross-matching in heart transplantation. I would provide a concise overview of the laboratory method to facilitate a better understanding of the obtained results and demonstrate how these tests correlate with clinical courses by sharing 3 patient cases. These are the current tests and concepts used to detect HLA antibodies, whether donor-specific or non-donor-specific. The test methods include microbead-based immunoassay, cell-based functional or binding assays, and the virtual cross-matching of histocompatibility. Essentially, a screening test is designed solely to determine the presence or absence of HLA antibodies in patients. For instance, microbeads are coated with multiple pools of multiple HLA class 1 or class 2 antigens, making it impossible to pinpoint the specific HLA antigen reacted with antibodies in patient's serum. Therefore, subsequently, the HLA antibody identification test using microbeads coated with single specificity antigens is needed. When specific beads show a positive fluorescence signal, we can have the information about the targeted HLA specificities, not only in antigen level, but also in allelic level. The current antibody test provides allele-specific information, which makes the applet analysis possible. However, the intensities of positive antibodies expressed as mean fluorescence intensity, MFI, do not accurately reflect the actual titer or strength, nor the cytotoxic function of antibodies. So the complement binding assays such as C1Q or C3D assay measure the complement component and a component bound to antigen and antibody complex, or derivatives from those complexes and complement interactions. These tests provide us the indirect information about the potential cytotoxic ability of detected antibodies, but without conducting actual CDC cross-match. We also can detect the presence of HLA antibodies by cross-matching either actual or virtual ways. Positive results in actual cross-matching tests indicate the presence of donor-specific antibodies in the recipient serum, even though the exact HLA specificities are unknown. The primary advantage of actual cross-matching is its provision of direct evidence of the antigen and antibody reaction. However, to conduct this test, fresh viable donor cells and the recipient serum are needed, which can be impractical without a living donor or during the post-transplantation period. These are 2 types of actual cross-matching tests which currently used in most of the laboratories. One is the CDC cross-match using detecting the complement-dependent cytotoxic antibodies, and the other one is flow cytometry cross-match, which only detect binding, but actually it detects both complement-dependent and independent antibodies. Both antibodies demonstrate the direct interaction between donor and recipient, yet they do not provide information on HLA specificities. By utilizing information obtained from specific and sensitive antibody identification method, along with high-resolution HLA typing, the virtual cross-match becomes feasible. This involves predicting the cross-match between donor and recipient based on the specific HLA antibody profiles of the recipient and the HLA type of the donor. This approach could be particularly valuable in urgent situations for making quick decisions regarding transplantation or desensitization treatment. and it is essential concept for monitoring donor-specific antibodies post-transplantation period. I'd like to share cases with you. The first patient was a 52-year-old female diagnosed with hypertrophic cardiomyopathy. She was very highly sensitized with CPRA, 99% for class 1 and 90% for class 2. After a round of desensitization, her CPRA still remained high. And following another round of desensitization, still high. But a deceased donor was matched, and then based on the donor's HLA typing, we found that the patient has DSA to HLA-B62. And the intensity, the fluorescence was about 4,000. But the C1q binding assay was negative, and the CDC crossmatch was also negative, although flow cytometry crossmatch has slightly weakly positive in T cell phage. The patient has undergone 2 more cycles of plasmapheresis, and they remain to have a low level of DSA at day 30. This is a little complicated table, but this is a summary of the pre-transplant single antigen identification result. Despite consistently high CPRA, the distribution of antibodies based on mean fluorescence intensity actually changed over time with desensitization treatment. One significant observation, what we observed was that the presence of multiple DQ antibodies in patient serum. Although the donor DQ type were not provided by CONUS at the time of transplantation. So we used HLA-DR and the DQ linkage disequilibrium data to predict the donor type, and then assuming that DQ7 and DQ6. And actually this led to the identification of another DQ7 DSA in the recipient. In the post-transplantation, the patient encountered acute allograft cellular rejection and antibody-related rejection with presence of donor-specific antibodies. But since then, despite the persistence of low-level DSA, there was no evidence of rejection, and the patient's overall condition is currently favorable for over 700 days. With this case, we are able to address several issues such as efficacy of desensitization and the effect of C1q binding assay and the different sensitivities of cross-match method, and also the necessity of prediction of DQ type. And also, we need to think about the significance of persistence of low-level DSAs, even without the evidence of allograft rejection. This next case is 15-year-old male patient diagnosed acute myocarditis. The patient did not have preformed DSA and had a negative antibody test along with negative finding on biopsy at day 11. By day 31, high level of DQ7 and the DQ9 DSA were detected. Despite this, there was no evidence of acute allograft rejection in biopsy. These antibodies might be de novo DSAs or as a result of DSA emerging from pre-sensitized by LVAD. On day 60, there was a finding of acute allograft rejection with reduced level of DSAs. But since then, the patient continued to have low to moderate levels of DSA without evidence of rejection up to 106 days. So in this case, we consider the 2 issues like presence of post-transplanted DSA after LVAD and the significance of persistently low-level DSA. The last case is 56-year-old male patient diagnosed with dilated cardiomyopathy. Like case 2, the patient didn't have preformed DSA, and post-transplantation DSA until day 65. Actually, I didn't show here, but it was negative until day 65. However, the patient condition needed to exclude immune rejection at around day 50, so we decided to conduct non-HLA autoantibody test. Antibody to multiple autoantigens, including vimentin, were detected. And almost at the same time, the pathology findings suggested non-HLA antibody-mediated rejection. Interestingly, by day 71, actually DSA to B62 appeared. But unfortunately, we could not obtain further information about antibody profiles because of fatal clinical course following desensitization treatment. In this case, we assume that the non-HLA autoantibody, such as anti-vimentin antibody, played a major role in occurrence of antibody-mediated rejection, but subsequently, it might have primed the production of HLA DSAs as well, and contributed to worsen the clinical course together. As up to 40% of antibody-mediated rejection in the absence of HLA DSA reported in heart transplantation. Non-HLA antibodies seem to be an important player to induce antibody-mediated rejection in heart transplantation. Nevertheless, there are evidences that HLA DSA and non-HLA antibodies interplay to facilitate the production of each other during pre-transplantation, transplantation, and the retransplantation period. Therefore, it would be important practice to investigate both antibodies for explaining antibody-mediated allograft rejection in heart transplantation. Thank you for listening.